Again, welcome to our third seminar in our Modern Methods in Social Policy and Intervention Research series. My name is Mark Fransham. Here, I'm a departmental lecturer and a senior research officer here at the Department of Social Policy and Intervention. I'm very pleased today to welcome Professor Scott Cunningham from Baylor University. Scott is going to be talking us today about on a talk entitled Indigent Defense, Social Workers and Suicidality in Jail, Evidence from Randomized Clinicians and Instrumental Variables. So Scott is, as I say, a professor of economics at Baylor University. He studies a number of topics, including mental health care, sex work, abortion and drug policy, with articles published in the Journal of Economics, the Journal of Health Economics, the Journal of Human Resources, and the Review of Economic Studies, among others. He is well known as the author of Causal Inference, the Mixtape, an accessible contemporary introduction to the methods for determining cause and effect in the social sciences. The book was published by Yale University Press in 2021 as a physical book, but is also very generously made available as a free HTML version on his website. And I can thoroughly recommend it to anyone who wants an introduction and indeed, an update on some of the frontier developments in the key methods for assessing, for establishing causal effects in the social sciences. Scott also has a new blog, Causal Inference, the Remix, which contains regular medium-length explainers on new working papers in economics, which highlights recent developments in causal inference methods. So many thanks to you, Scott, for being with us today. And if I may, I'll hand over the virtual floor to you.
Thank you, Mark. Thank you for having me. I'll go ahead and start. I've got about 33 slides, so hopefully it's not overwhelming. I'm going to be talking about things that are not even well known in the United States, but are probably even less well known in Europe. And so if anything doesn't make sense, if you could just pause and ask me to explain it, I don't mind doing that. It's not always easy to know exactly what is not coming across. When you're talking about something that you've been studying for a long time, you can forget that this is new for people. So this is a paper with Vivian Vigliotti, a recent graduate at Baylor's Health Services Research PhD program, and Jonathan Seward, a PhD student in the program. We've been working on this project for, I guess, a couple of years. Let me tell you about it. So probably everybody on the line is familiar with the Black Lives Matter movement in the United States. It's a large civil rights related movement, very grassroots, focused on racism in the criminal justice system. And it's had unfortunately, several tragic touchstones that kind of caused it to grow. One of them was the death of Sandra Bland. Sandra Bland was a 28-year-old African-American woman in Texas. She was pulled over for a routine traffic violation with a white officer in a rural county of Texas, but it caused an argument and she was arrested. 3 days later, she was found hanging in her cell, and it was ruled suicide by asphyxiation. Led to protests around the country against her arrest. There were disputes about the cause of death. There were allegations of violence. And ultimately in Texas, it led to the Sandra Bland Act. And as a result of the Sandra Bland Act, county jails in Texas are required to collect information at booking to determine whether or not a person has mental illness or any other intellectual disability. Written assessment is submitted to the judge and to a mental health expert, and then housing decisions are made based on it. So the backdrop of this paper is Texas, the state Texas. We're going to be looking at a specific county in Texas, which is the county seat of Austin, Texas. You may be familiar with the city of Austin. It's a large city like Dallas or Houston. In Texas, it's the capital. So we're going to be looking at mental health in the criminal justice system in Austin, Texas, and we're going to be looking at suicide in the jails. So we're looking at suicide because it is the leading cause of death in jails. It accounts for a third of all deaths in jails, and it's 6% of all deaths in prisons. Pretrial inmates or detainees have a suicide attempt rate. It's 8 times higher than the general population. So it's a major health problem in the United States. It's a major justice problem in the United States. So I said that we're going to be looking at one particular county in Texas called Travis County. So the context of this study is something called a mental health court. Mental health court. So in the United States, there has been many movements for reform because we house so many prisoners. We're the world's leading, we lead the world in imprisonment. We have over 2 million prisoners. We have over 4 million on community supervision. We have the highest incarceration rate, both for adults and kids of any country in the whole world. And in that context, there is a lot of people that are in jail or prison that arguably need other help. They need other forms of help than simply prison or jail. And one part of that population are people with mental illnesses. So the United States, because we incarcerate so many people, we have actually begun to incarcerate our mentally ill population. They'll commit offenses and then they'll get trapped in our criminal justice system. And so part of a reform that happened starting in the late 90s was the mental health court movement. And the mental health court movement was sought to create new courts with new dockets in counties that would siphon off defendants that had mental illnesses and treat them differently. They would go into a friendlier court. It was not an antagonistic court. And really the whole goal of most of these courts was just to dismiss the charges best that they could. And that's going to be the context of this project. We're going to be looking at what goes on inside one particular mental health court. But inside that mental health court is defense attorneys. So you have judges, you have prosecutors who represent the state that are prosecuting the case against the defendant, and you have defenders. Most of the people in our sample are poor and they cannot afford to hire an attorney. But in the United States, our Constitution has an amendment, the 6th Amendment, that requires cities and governments to provide a public defender if the person can't. And in Texas, actually across the whole country, lots of jurisdictions satisfy the 6th Amendment in different ways. And in Texas, in our mental health court, we do it in 2 ways. You either are given a public defender who works for a public defender's office. They're a licensed lawyer who has focused exclusively on mentally ill defendants. And this public defender office has employed a large number of what are called social workers. Social workers work directly with the defendant. They make sure that they get to the court on time. They make sure that they're enrolled in government services. They help them get on their medication. They help them get housing. They're providing a lot of non-legal help to the mentally ill defendant. So there's a public defender's office that has all of that extensive staffing. And then there's a private system. And the private system is, individuals like you and me that might have our own business. And then on the side, we'll take on some cases. And these individuals take on mentally ill defendants, either because for some sort of altruistic reason, meaning they just simply want to give back to the community, or because their regular job isn't paying enough, and so they'll take on extra work. They do not have access to the social workers. So you have these two types of lawyer representations representing both all of the mentally ill defendants. One of them is kind of being given a large number of social workers, and one of them is just kind of being given just the legal counsel. Okay. And so what we're going to be doing is we're going to be estimating the effect of the public defender with its large staff of social workers on suicide and repeat offending as compared to the private attorneys that have no social workers. All right. Okay. So how are we going to do this? So we're going to have to use a method. Everybody's familiar with it. It's called instrumental variables. We're going to have to instrument for being assigned to the public defenders because it's not random. You're not randomly assigned public defenders versus private indigent defense attorneys. In fact, the worst defendants, the people with the worst mental illness symptoms, are in Travis County assigned to the public defender because they have large numbers of social workers, and those with moderate symptoms are allocated to the private and indigent defense attorneys. So you've got this non-random assignment. What we're going to do is we're going to use a popular instrumental variables design in criminal justice called the leniency design. And what the leniency, or sometimes called the judge fixed effects design, and what this does is it instruments for your assignment to the public defender using your average, using some instrument that is, well, let me get into it. So actually, I'll tell you a little bit more about the instrumental variables in just a second. Let me just summarize what we're going to do. So we're going to instrument for assignment to the public defender's office to get around that non-random assignment. And what we're going to find is that public defenders with social workers have no effect on whether or not a defendant re-offends. So public defenders and private defenders are equally likely. Defendants with any type of lawyer are equally likely to commit another offense. But if you are assigned to a public defender's office, your mental health improves. So upon reoffending, your mental health scores, there'll be this clinician that's going to review you that I'm going to discuss in a second. Their mental health scores improve, so they look much better, even though they've reoffended, compared to those people that had a private attorney. But their suicide attempts in jail fall between 7 and 16%, depending on the modeling specification that we use, and their self-reported suicidal ideation. Suicidal ideation means expressing any kind of desire for suicide. Self-reported, that falls 1 to 2%. The effects are largest or more precise for those people that have never committed a prior offense and that have never had been treated for mental illness before. So these are basically first time into the criminal justice system, first time being identified as a person with a mental illness. So let me tell you about the mental health courts, and let me tell you about the experiment. So jails in the United States basically house a gigantic population of mentally ill people. Inmates in the United States are 64% or 12 times more likely to have a mental illness than your average American. In most states, there's at least one jail or prison that houses more mentally ill people than the largest mental hospital in the area. So we're really depending on our jails to treat mental illness in the American population. 20% of inmates in our data require treatment for their mental illness on any given day. On any given day, 7% of inmates with mental illness are experiencing severe symptoms, psychosis, delusions, suicidal thoughts. Prevalence rate of mental illness amongst people who committed suicide is about 77%. So it's actually a major element of our criminal justice population. It's not often spoken about, and I don't know why. I don't think it's commonly known even in the United States. So why are there so many mentally ill people in our jails and prisons? Has to do with two things. One is under President John F. Kennedy and President Ronald Reagan in the 60s and the 80s, the United States began to close our mental hospital facilities through a widespread defunding. We defunded our mental hospitals. And as a result of that defunding, the hospitals closed. So there's fewer residential hospitals in the United States. At the same time, there have been tremendous medical breakthroughs in treating mental illness. Lithium treating for bipolar, clozapine for treating schizophrenia, and SSRIs for treating depression. So even the demand for the hospitals have declined. So there's been both supply side reductions in hospitals, and there's been demand side. But there's also been this push towards community-based treatment, and that actually was unsuccessful. There never really, according to people that write in this area, the hope that communities would take on this mentally ill population just never materialized. And so as a result of this deinstitutionalization, the United States has a very large homelessness problem. We have a very large number of homeless individuals with mental illness who probably would have been in hospitals were it not for this deinstitutionalization. Second thing that's happened, though, is at the exact same time that deinstitutionalization happened, the United States began a grand experiment with mass incarceration. We had a 500% increase in our prison population from the 1970s, 1975 to the present. It's largely driven by increased penalties for any type of criminal offense. It's not just our war on drugs, as it's called here domestically. It's really more of a generic assault on, or not assault, but a war on crime. And people with mental illnesses just kind of got sucked in to this growing prison population. They'll commit various offenses. Many times they don't have family support anymore. They're homeless, they'll commit an offense, and then they'll just get kind of stuck in a cycle of reoffending, and then they'll end up in jail, they'll end up in prison, and their lives are lost. So the mental health court movement emerged because of what I just said, and what it sought to do was to target people with mental illnesses and get them out of that cycle. They wanted to get them out of that cycle. And the way that they did it was they created a separate docket in a separate court with specially trained judges and specially trained attorneys whose sole goal was just to get the charges dismissed. They wanted to make sure that the person was stable And so they were seeking follow-up treatment, but by and large, they were seeking just to disentangle them. And there's a lot we don't really know about how well these mental health courts work, because they differ so much across the country. There's over 600 of them, and there's no single version of what a mental health court does. So evaluating them is kind of hard. But with the typical court, essentially a person is screened for a mental illness. If they do not have a mental illness, they go to a typical court. If they're convicted, they go to jail. If they have mental illness, they'll likely receive medication for their mental illness while they're in jail. If they're in a mental health court, MHC, they're diverted from those courts, and then they will work directly with the judge and the attorneys. Now, in Travis, I said that Travis County, Texas, Austin, Texas, will have two types of attorney systems. Both of them are required by the Sixth Amendment, or rather, some representation is required, some free representation is required by the Sixth Amendment, but every jurisdiction actually can satisfy it in many different ways, and there's lots of different ways. So one way is this private system. And what happens with the private system is that attorneys are paid a flat rate. That's not always what's done in the United States. Sometimes they'll pay them by the hour, but Travis pays them $750, period. No matter how many hours you spend with the client, you only get $750. So there's really not an incentive to spend a lot of time with a client under this system, because you get $750 whether you spend 1 minute with a client or whether you spend 100 hours with a client. Okay, so this is the system that is used in Travis, though, and it's not an uncommon system used around the country. In 2018, there were 6 lawyers in the mental health court that did this. They largely did it for extra money. They get extra training on mental health. They also do it for altruistic reasons, to give back to the community. But there's about 6 of them. And then there is, and these individuals are going to get people, hold on. Oh, I left it out. So these individuals are going, I left out the discussion of the instrument. 1 second. Yep. Okay. All right. So I do discuss it in a little bit. So we're going to get the people with the moderate mental illness. I'll explain the score in a second, but let's just say that they have moderate symptoms. If they're found to have moderate symptoms, they go to the private attorney. If they're found to have severe symptoms, these people are very low functioning individuals with mental illness, they go to the public defender's office. And the public defender's office has 4 lawyers, 4 salaried lawyers, 6 social workers, 2 admin staff. None of that describes this group. This group has no social workers, no admin staff. All right. So what we're really going to be doing is we're going to compare the public defender's office with the private attorney, but the differences between these 2 lawyers are partly selection. The private attorneys typically are moonlighters, and then the public attorneys have more resources. They have, independent of the selection, they have social workers who are doing a lot to help the defendants. Okay, so let me tell you about the data. So it took a long time to get this data. We basically had to build relationships. You couldn't do a public records request for this data because it's healthcare data. We had to basically build relationships across the county with various stakeholders. We had to go before a particular administrator called the sheriff. It's a sheriff's office. It's a police department. Had to meet with the sheriff, which is the head police officer for that agency, and just convince her that this was a project worth doing. And she agreed. Thankfully, she agreed. So we've been working with the Travis County Correctional Complex, which is just a jail, and used their data from 2016 to 2019. Okay, so we have 4 years of data. We have every single booking, which is 40,000 inmates. We reduce it to 31,000 because we want to only use those individuals that are meeting with a therapist for the first time. All right, so let me tell you, before I discuss this, let me tell you what this experiment is. All right. So when you're booked, an inmate will be randomly assigned to a therapist. A therapist is someone with a licensed clinical degree, usually. It's either going to be a licensed clinical social worker or it will be a licensed professional counselor. A couple of times it's a PhD. There's about 60 different therapists that the jail employs, and you're randomly assigned to one of them within 36 hours of booking. They spend 15 minutes with an inmate. And all that they're doing in the inmate is they're going through a survey, and they're asking the inmate different questions about the person's daily functioning. So they're going through and they're answering yes or no questions, but they're also observing the inmate. And at the end of the interview, they rate the inmate on a scale of 0 to 3. And the 0 to 3 measures the severity of their symptoms at that, as they best can tell. They use kind of different criteria for this, and that's going to be a key part of the instrumental variables design. But they all have to come down and say something between a 0 and a 3. And if you get a 0 or a 1, then you don't go to the mental health court. That means your symptoms are so low that you don't meet criteria for the mental health court. They can't do the mental health court for everybody. If you get a 2, then you're assigned to the private attorneys. And if you get a 3, you're assigned to the public defender. Once you are assigned to a public or a private attorney, you never see these therapists again. These therapists are not providing health care. These therapists are only screening the inmate on the severity of their symptoms. Okay. So what we're going to do is we're going to use the 31,000 inmates who see a therapist for the first time. Okay. So these are unique encounters with a therapist at first booking. We're going to have information about the type of offense, whether it's a felony, which is a more severe, offense, or whether it's a misdemeanor, which is a smaller one. And we're going to be looking at just the misdemeanors, but we're going to allow you to, when you reoffend, to reoffend with a felony. We're focused on misdemeanors because we have less measurement error with the court assignment when we look with misdemeanors. There are felony assignments to public defense, but they're a lot more complicated, and we're not able to be 100% sure that we've got it correct, but we're 100% sure we know we've got the misdemeanors. We've got demographics, we've got their mental health symptom scores, we've got the charges, we've got whether or not there is a suicide attempt that's happened in the jail, whether or not they've expressed suicidal ideation, and that's it. So we're worried about bias. We're worried about different sources of bias. One is we're worried about what's called collider bias, which I'll show in a second. And we're worried about unobserved selection that therapists witness. So we're going to use the instrumental variables, and we're just going to check. We're going to provide some auxiliary checks to whether or not we have a collider problem. We're going to estimate the local average treatment effect, which is all that instrumental variables can estimate, of public defenders with social workers. on repeat offending, suicidality, and mental health using two-stage least squares and unbiased jackknife IV estimation, as well as an IV lasso model. We're going to present some evidence that monotonicity holds. So here's the assumptions of IV. You need randomized assignment of the instrument, and we know that we have that. We'll provide some evidence for it, but we've spoken with the director of inmate mental health, and he's explained that they use a random number generator to assign each inmate to a therapist, right? So we have independents or random instruments. Sattva requires that when I'm assigned to a therapist, it can't change the suicidality of a different inmate. So if I'm assigned to a particular inmate, Sattva requires it has no spillover to another inmate. That really can't happen because of the limited interaction that these inmates are going to have with each other, but also they're not providing any health care. So there's really not a lot of influence that peer effects could have because they're not really doing anything to these defendants that could change them. The exclusion criteria is easier to explain with a graph, which I'll do that, as is the non-zero first stage. The big one, though, is monotonicity. Monotonicity means if I have two therapists, therapist A and B, and if therapist A always rates an inmate as having low functioning, then therapist B, then therapist A would have always recommended public defenders every single time therapist B did it, and sometimes more. So monotonicity means if therapist A is more strict than therapist B in any situation, they are always more strict, okay? Monotonicity is usually where things fail in these designs. So I'll try to discuss some evidence for it. So we're going to look at a directed acyclic graph. And this directed acyclic graph is showing being assigned to a public defender, whether or not it affects suicide directly, and whether or not it affects recidivism. So hopefully I can explain what my experiment looks like here. I've got this instrument that we're going to construct, and the instrument is basically the average tendency of a therapist to recommend public defenders. It's basically how severe, on average, is a conclusion of a therapist in our data. So, let's say that I recommend, I say that you have severe symptoms 60% of the time with all my other cases. That's going to be my instrument. I'm going to instrument for whether or not I was assigned to the public defender's office with my average severity rate. And the average severity rate for everybody else, that should have nothing to do with the underlying characteristics of the inmate. That should just have to do with my tendencies if I have random assignment of inmates to therapists. So I'm going to instrument for whether or not you went into public defenders with just how likely do I do it anyway. Now, being assigned to a public defender can cause you to reoffend. So we're going to have this direct effect here. And if you reoffend, I'm going to see you in the data. And if I see you in the data, I'm going to be able to check and see if you tried to commit suicide. Okay. Now, what I have lots of characteristics that cause a person to get assigned to a public defender. I've also got a lot of characteristics that causes a person to reoffend. I've got these unobserved factors independent of this instrument that causes a person to reoffend, and those unobserved factors might also cause that person to attempt suicide. So that has implications for this study because the only data that I have on suicide comes from the jail sample. So that means I'm only able to check for the effect of public defenders on suicide by working with a recidivism sample, right? And that's going to be problematic because public defenders, if they cause recidivism, recidivism is the child in a directed acyclic graph of both being assigned to a public defender and these unobserved characteristics of the inmate. Now, when I have a causal chain like this, public defender causing recidivism, which is caused by the unobserved factors, which cause the outcomes, I have two arrows focused on recidivism. Now that means that recidivism, that means my sample is a non-random sample that is functioning as what's called a collider. And the nature of a collider is that it blocks any correlation between public defenders and the outcomes via that channel. Normally blocks it, except when you condition on that collider. And when you condition on that collider, if it is a collider, then public defense and suicide end up being spuriously correlated. You'll get false positives or false negatives. But if there is no effect on recidivism, then this chain doesn't exist in the first place, and we're able just to look at the effect of public defense on suicidality. So we're going to check. We're going to check and see if public defenders have any effect on recidivism, and if they don't, then we're going to be able to use our sample to evaluate the effect of public defense on suicidality. Now I'm going to skip this part because I'm running out of time. We're going to estimate this two-stage least squares. We're going to use different models. We're going to use two-stage least squares. We're going to estimate a model called the unbiased jackknife IV estimator, or jive. And we're also going to estimate something called lasso. Our results never change. Our results never change. So let's look and see what our results are, right? So therapists, first main thing is, even though therapists are on average seeing, on average, the same inmates, they disagree with each other considerably. This is a distribution of the clinician fixed effects, and they're all being compared to some particular baseline, some sort of particular clinician. And you can see that if they all agreed with each other, if everybody agreed with a person's mental illness symptoms, then the clinician fixed effects would not be significant. They would be basically along the zero, and they're not. They're off the zero, which means that if you're assigned to this clinician right here, there's about a 45% more likelihood that you'll be assigned to the public defender's office, even though you were randomly assigned to that person. They are systematically more likely to give you, to say that you have severe mental illness symptoms. They're saying that you have more severe mental illness symptoms, even though they're on average seeing the exact same clients as anyone else. So it's a tendency. There's a tendency for these therapists to not agree with each other considerably. It's only a 15-minute interview, so that could be part of it. You can see right here, as we move from left to right of that average, this is a normalized propensity to recommend public defenders. This is a normalized, recommendation, tendency to see severe mental illness symptoms. You can see that as you move across and are being assigned more and more to these really, people that tend to see mental illness symptoms, the sample of inmates assigned to public defenders grows. There's a positive correlation between the propensity score and the assignment itself. You can see, though, that across the distribution of that instrument, so this is just the recommendation rate. It's all normalized to zero. But basically, this will be a person who's like, 40% of the time recommends severe mental illness versus, the rest of the time recommending moderate, well, you can see that across this distribution, they see the same number of Asian. These are p-values on whether or not these means are different from each other. You can see right here, hardly any of the p-values are statistically different. Here's one where these p-values have a p-value less than 0.05. So people that are high recommenders of mental illness, they see about the people with the highest recommendation rate, 25% of their clients are African-American versus 28%. So these are still very small differences, but all of the demographics are fairly balanced across these inmates. All right. So there's a very strong first stage. We get a Clyde-Bargan PAP-F statistic of 17. If you're assigned this, sorry, I'm running out of time. So if you're assigned to this, if you're assigned a strict judge, a strict therapist, there's a 64% higher chance that you'll be assigned to the public defender's office. All right, so let me get to the main results. There are no effects on recidivism. So we really want to look at these results right here. This is recidivism. There are no effects on recidivism. No effects on recidivism within the first year. No effects on the number of future offenses. No effect on days to recidivism. No effect on whether or not the next offense is a felony. So that means, that we have no collider. So we don't have to worry about this collider channel. We can look just at the effect on suicide and know that we're not picking up any kind of collider effects. So let's see what we find for suicidality. If you are assigned to the public defender's office with its 6 social workers compared to the private indigent defense attorneys who have none, looking at our 2-stage least squares, these are our main models right here, one with without baseline demographic controls and one with. You can see that being assigned to the public defender reduces suicide attempts by 12 to 16%. It reduces suicidal ideation by 1.4 to 2%. I've got confidence intervals here. Okay. Goes anywhere from negative 0.003 to negative 0.037. And the booking mental health score, which goes from 0 to 3, improves by a full point. So if you're in the public defender's office and you reoffend, you'll come in on average with 1 point improvement. On a scale of 0 to 3, you'll see on average your health scores improved by 1 point. That could be because you went from, a 3 all the way down to a 2, or it could be because you went from a 3 to a 0. The people that appear to be most benefiting are people without prior diagnoses. Prior treatment, no. Prior medications, no. Prior hospitalization, no. Okay, so we're finding suicide attempts are falling for the people without prior treatment, without prior hospitalization. Suicidal ideation falls for people without prior treatment, people that had never been on medication before, people that had never been hospitalized before. And the improvement is happening amongst the undiagnosed individuals. So it's catching these people who have no prior knowledge that they're mentally ill, is what it looks like. Those are the people that are benefiting from these social workers. When we look at the jive model, which is a jackknife IV estimator that handles all of these clinician fixed effects. So the instrument's going to be all 60 clinician fixed effects and not the propensity score. You see that, again, suicide attempts fall between 10 and 13.8%. Suicidal ideation falls between 2.4%, a little bit imprecise over here. and mental health scores improved by around 0.8 to 0.9 points. The effects are larger amongst people without a prior offense. We find some weak evidence for prior criminals, but for the most part, the effects are more precise for people without a prior offense. We also do something called the IV lasso. It's a machine learning based model. Remember, we have 60 clinicians randomly assigned. Those can be used as the instruments. You can either use the propensity score or you can use the clinician fixed effects. They're actually algebraically equivalent. And so when we use IV lasso, when we use jive, you've got 60 instruments, many of whom might be weak. And the more weak instruments you have in an IV model, the closer you are to the bias of two-stage least squares blows up. Two-stage least squares is only consistent. It's not unbiased. So we're going to use the IV lasso model. The IV lasso model, what it's going to do is it's going to shrink those clinician fixed effects that are weak. It's going to pick those ones that are the strongest instruments. And when we do that, our results really don't change. They get a little smaller. Suicide attempts here are negative 7.6%. They're smaller for the people without a prior offense. They're larger for people that have prior offenses. This is the first time we're finding any effect on prior offense. Suicidal ideation, extremely precise. Again, it's a 2%. We find larger effects for people with prior offenses. This is prior offenses, not prior diagnoses. So repeat criminals are benefiting more from getting those social workers. And we're finding across the board improvements in mental health. So public defenders are relatively impactful at decreasing suicide attempts and suicidal ideation and improving the functioning of an inmate if they do re-enter the jails. So it's not deterring, it's not reducing repeat offending. So the public and private attorney system is having no effect on repeat offending. What it's having an effect on is mental health. It's possible this is driven by lawyer type, but because we find no recidivism effects, we think this is actually driven by the social workers. It's the work of the social workers that is benefiting the inmates or the defendants, we think, not really the lawyers. That's also from speaking to the people that run the system in the city. Very few of them think that the lawyers really are all that important in the mental health court. And that's because the whole goal of the mental health court is just to dismiss. There's very little, it's not the typical kind of lawyer work that you think of with courts. Both the prosecutor and the defense attorney and the judge are working for the same goals: get the cases dismissed. And so for that reason, that might be why there's no difference in recidivism, but there is differences in mental health. This is probably important because if you've heard anything in the United States about this movement associated with Black Lives Matter, it's called defund the police. There's a movement in the United States to basically shrink our police department size and take some of the resources of the police department and reallocate them to communities in basically social services. It's only a matter of time before we see discussions move away from the police and probably focus on all criminal justice, including the courts. And so you can imagine mental health courts being an important part of this. And we don't really know how these mental health courts work, and we don't know what helps these inmates. But what appears to help them is getting them to social services, specifically the social workers. So figuring out which elements work is essential in the United States and really around the world. Figuring out which parts of the mental health court system works is going to be key to going forward to any kind of policy reforms on our criminal justice system. But it looks like what we need is, if we are going to be trying to improve their mental health in the jail, getting them help via the social work institutions could be a key way to doing that. And that's it. That's my talk.
Thank you very much, Scott. Thank you. That's absolutely fantastic and really, really fascinating, both substantively and also from a methods point of view as well. So thank you very much. Thank you very much indeed.